In this recording, we will discuss pulmonary ventilation. As we've discussed, one of the basic functions of the respiratory system is gas exchange or respiration. This process includes the exchange of oxygen with carbon dioxide, and it's technically four distinct processes or steps. We have pulmonary ventilation, and often that's just referred to as ventilation, which is the movement of air in and out of the lungs. And then we have pulmonary gas exchange, which allows us to exchange oxygen and carbon dioxide between the lungs and the pulmonary capillaries. And then we do gas transport, so the oxygen that we just picked up from the lungs, we transport it throughout the body. And when we get to the tissues, we do tissue gas exchange, so we will dump off the oxygen into the tissues and pick up the carbon dioxide to take it back to the lungs. Now, the first step, okay, breathing, pulmonary ventilation, whatever you want to refer to it as. We have two parts. We have inspiration and expiration, okay, or if you prefer the terms inhalation and exhalation, that's fine. Inspiration is bringing air into the lungs. Expiration is moving air out of the lungs. So you're breathing in and you're breathing out. There is a relationship between pressure and volume, which drives the force of pulmonary ventilation. And that relationship is, if volume changes, this will lead to a pressure change in a very specific way that we'll talk about on the next slide. These pressure changes lead gases to flow in one direction or the other to try to equalize pressures. And gases will move in a way that they will always try to fill the containers that they are in. In our example, that container would be the lungs filling up the thoracic cavity. So we will take in air in an attempt to fill the lungs to fill the thoracic cavity. So that relationship, that specific relationship between pressure and volume, okay, it's known as Boyles Law. Boyles Law says that as volume goes up, pressure goes down. As volume goes down, pressure goes up. So this is an inverse relationship. And in our cute little picture here, we have a syringe. It's capped at first. We've got some gas molecules floating around inside. If you leave it capped, so notice in our image, we're not taking the cap off. Okay. Okay. As you leave the cap on, if you pull the plunger back to increase the volume, the pressure goes down. If you push the plunger in, again, still capped, okay, your volume goes down, but your pressure goes up. Okay. So again, inverse relationship. Volume goes up, pressure goes down. Volume goes down, pressure goes up. Now, the air that we breathe, okay, it's not just pure oxygen. The air that we breathe is actually a mixture of several different gases. Okay. The one we care about is oxygen, okay, but that's not the only component of the air we breathe. In fact, it's not even the main component of air that we breathe. But the air as a mixture, okay, the movement of the air is dependent on pressure gradients. Okay. You are super familiar with the idea of substances moving from a high concentration to a low concentration. Okay. So this idea should be somewhat familiar to you. In this case, gases are going to move from an area of high pressure to low pressure. Okay. We're going to go from high to low still. We have three pressures that we're going to need to keep in mind. Okay. You are going to want to remember the differences between these. Okay. First of all, atmospheric pressure is just the pressure exerted by the air surrounding your body. At sea level, this is 760 millimeters of mercury. Sometimes you will see that referred to as 1 atmosphere, 1 ATM. Okay, it's not where we get the money, it's 1 atmosphere. Okay. Notice we do say at sea level. Okay. If you go really high up or really low, below sea level, this will no longer be 760. This can change. Okay? But Unless we specify that we're really high up or really low down, we just refer to the atmospheric pressure being the 760. Okay. Now we have intrapulmonary pressure. Okay. Intrapulmonary, within the lungs. Okay, so this is the pressure inside the lungs themselves. This pressure is trying its hardest to equalize with atmospheric pressure. Okay, so it is not 760 millimeters of mercury, but it's trying to become 760 millimeters of mercury. Okay. And then we have intrapleural pressure. Okay, intrapleural, between the pleura. So this is the pressure between the visceral and the parietal pleural layers. This is always less than intrapulmonary pressure, okay, or negative to it. That does not mean it is a negative value, okay? It just means it is a lower number. This is a major factor that prevents your lungs from collapsing, okay? If your intrapleural pressure becomes equal to atmospheric pressure, your lungs will collapse. We call that atelectasis. You know that's bad. You know your lungs don't work quite as well if they're all collapsed. Okay, so we're trying to avoid that. These pressure gradients, okay, these differences in pressure are what drive the movement of air molecules during inspiration as well as expiration. Okay. All right. So we can take our cute little syringe. Okay. We're going to uncap him, y'all. We're going to uncap him. The process of pulmonary ventilation, which remember is just really breathing in and breathing out, inspiration and expiration. Okay. The volume changes within your thoracic cavity and the lungs themselves, okay, is what leads to the pressure gradients. These gradients cause air to move into the lungs or out of the lungs, okay, just like in our picture. So now that we've uncapped everything, okay, we've got gas molecules outside, got gas molecules inside, okay. Uncapped, we're going to pull our plunger and we're going to suck some of those gas particles in, okay. If we push our plunger down, we're going to shoot some of those gas particles out, okay. Same thing with our lungs. If we breathe in, air comes in. If we breathe out, air goes out, okay. Keeping in mind the changes in volume are also affecting the changes in pressure. As volume goes up, pressure goes down. As volume goes down, pressure goes up. Now, how do we achieve changing the volume of the lungs? Okay, so you already know that the only type of tissue in your body that can quote-unquote move on its own is good old muscle tissue. Okay, your lungs aren't exactly made of muscle tissue. Okay, we do have some smooth muscles on bronchioles, trachea. We've mentioned them previously, but the majority of your lung tissue is not muscles. So we're going to need some help if we want to move the lungs. We have, fortunately for us, skeletal muscles. Okay, within your thoracic cavity, we call these inspiratory muscles as a group. The lungs by themselves, again, they're just not able to move because they're not muscle tissue, but we have skeletal muscles that attach to the thoracic cavity. Okay, for example, your good old diaphragm, which is your main inspiratory muscle. You already know that your diaphragm is basically your natural dividing line between your thoracic and your abdominal pelvic cavity. Okay. We also have our external intercostal muscles, which are the little tiny muscles found between the ribs themselves. These are additional inspiratory muscles to help us with like deep breathing. Okay, if we ever need an extra deep breath, your diaphragm gets a little bit of help. Okay. These muscles increase the lung volume indirectly, okay, by increasing the volume of the thoracic cavity. So we're not pulling on the lungs, we're going to pull on the thoracic cavity. Okay. The parietal pleura is attached to the inside of the thoracic cavity. And so as the thoracic cavity expands, okay, the parietal pleura gets pulled on, which pulls on your visceral pleura, which pulls on the lungs themselves, which increases the lung volume. Okay, I know you really got to wrap your mind around that one, right? Like lots of pulling going on. Okay, so your inspiratory muscles pull on your thoracic cavity, which pulls on your parietal pleura, which pulls on your visceral pleura, which pulls on the lungs themselves. Okay. Now, unlike inspiration, okay, normal expiration is actually a pretty passive process. It does not utilize muscle contraction. Basically, if you want to breathe out, you just relax all the muscles that you just contracted. Okay? So when your inspiratory muscles relax, everything that you just pulled on, you are basically kind of letting go of, right? You're relaxing. So you were pulling on the thoracic cavity, which pulled on the pleura, yada yada. Okay, you're basically undoing all that. Okay, the diaphragm returns to its original shape, which pushes kind of upwards. It kind of shrinks the thoracic cavity, and then the lung tissue itself, okay, is capable of recoil. We have a lot of elastic tissue in there. So recoil of the lung tissue itself and the diaphragm relaxing, both of those work together to decrease the lung volume, okay, by decreasing the volume of the thoracic cavity. And when this happens, it raises intrapulmonary pressure above atmospheric pressure, so air will flow out of your lungs. Again, lots and lots of words. So why don't we look at this nice picture? Okay. So we're going to go left to right here. Step one is in between breaths, so quote unquote at rest. Okay. So in between breaths, diaphragm has this nice curved appearance. Okay. External intercostal muscles are just kind of hanging out. Nobody's really doing anything. Then we're going to breathe in. Okay. So we said inspiration requires the contraction of your inspiratory muscles. So you're going to contract your diaphragm, which pushes it down. Okay. Your external intercostals are also going to contract, which pulls everything kind of outwards. Okay. So these little arrows are kind of moving out. Diaphragm moves down. This increases the volume within the lungs by increasing the volume within the thoracic cavity. So notice the lungs are also moving out. I'm going to increase the volume there. And then to breathe out, to do expiration, we're going to relax your diaphragm. Okay, he goes back to his dome shape. Your external intercostals also relax. They go back in. Okay, all of that causes your lungs to do recoil. Okay, and there we go. Now, in addition to your good old diaphragm, okay, your good old external intercostal muscles helping with normal ventilation, we do have some accessory muscles. These accessory muscles are going to be used during forceful expiration. So not normal expiration. Remember, normal expiration, we're really just relaxing your muscles. Forceful expiration, we are going to recruit our internal intercostal muscles and your abdominal muscles. Okay. During forceful expiration, you are forcefully decreasing the size of your thoracic cavity. Okay. Which is why your abdominal regions and your back muscles are often sore after you have like a coughing fit. Okay, it's like one or two coughs here or there, probably not so much, but if you've got a cold or you got something like stuck in your throat, something like that, and you're continuing to cough, it is very likely that the next day, or even that same day, your abdominal muscles, your back muscles could be sore. Now, sometimes we can forcefully expirate by doing the Heimlich maneuver because somebody might be choking on something. So the good old Heimlich maneuver, basically what ends up happening is you are delivering abdominal thrusts that push up on the diaphragm. Okay. If you ever have to do the Heimlich maneuver on someone, please make sure that you are not just pressing on their stomach. That's not going to be super helpful. We need to get right up under that xiphoid process and kind of pull up, to make sure that we are engaging the diaphragm muscle, not the stomach. Okay. We're doing this for people that might be choking in hopes of dislodging whatever it is they are choking on to restore normal breathing. Okay. Now, non-respiratory movements. These are things that you do all the time. Okay. Probably never really thought of them as respiratory movements because you're not actually, doing gas exchange with these. But again, you do these all the time. You sigh, we yawn, we sneeze, we cough. Okay, do all kinds of things. Sighing, slow, deep inspirations, held and followed by slow expirations. Basically, you are reopening little groups of collapsed alveoli, and this stimulates the release of surfactant, which helps prevent additional alveolar collapse. Okay. You could yawn, okay, which is basically just a really large sigh. Okay. This takes your lung volume to your inspiratory capacity. When you are tired, this minimizes your alveolar collapse during sleep. Okay. After sleep, this opens up your alveoli that did collapse during sleep as well, so it's not uncommon for you to yawn right before and right after you wake up. Okay. Or right before you go to bed and right when you wake up. Sneezing. Everybody has sneezed. These are deep inspirations followed by a large, forceful expiration through your nose. Okay. Y'all, velocity of about 100 miles an hour. That's crazy. 100 miles an hour for a sneeze. This helps clear foreign or irritating substances from the nasal passages. If you needed any more reason why you need to cover your face when you sneeze, hopefully learning a velocity of 100 miles per hour does it for you. Okay, please. If you are sneezing or coughing, we'll get into coughing here in a second, okay? Please make sure you are covering your face, okay? Coughing, kind of similar to a sneeze, except the initial inspiration is pretty small or absent altogether. We don't really take in a deep breath in before we cough, okay? But the velocity here can be even greater, 500 miles an hour. Look at here, y'all, cover your mouth. Cover your noses. Okay. This helps you not just clear your nose, but this is also helping you clear your larynx, trachea, and even some of your lower airways. Okay. So it should make sense that this is a more forceful and a faster, okay, movement, since we are clearing much more of your respiratory passageways. Now, we've been saying a lot of words. Okay, we've been throwing around lots of pressures, lots of muscles, things like that. So let's make sure we're going to put it all together real quick. Okay, these numbers. Okay, now we did mention 760 millimeters of mercury for atmospheric pressure. We said that was at sea level. If you would like to remember that number, I think that would be fine. Okay, I would not necessarily tell you needed to go home and memorize all of these other values. Okay. These are just references, so we can give you an idea of what's going on. Okay. So between breaths, when your intrapulmonary pressure equals your atmospheric pressure. Okay. This is true. Atmospheric, intrapulmonary, both at 760. Remember, intrapleural should always be negative to intrapulmonary. or less than. Again, notice this is not a negative number, but it is less than intrapulmonary, and not even a whole lot less. Look, 760, 756. So we're not talking about huge differences here. Okay. Now, inspiration. Remember, your lung volume is going to increase, which means your pulmonary pressures are going to decrease, your intrapulmonary pressure specifically, okay? And your intrapleural. Atmospheric pressure is not going to change. Okay, atmospheric pressure does not care if you're breathing out. It does not care if you're breathing in. Honestly, it's kind of rude. It doesn't care if you're breathing at all. Atmospheric pressure is what it is. Okay, but what do we care about? We care about the fact that we started at 760 with atmospheric pressure. We have not changed that. We started with 760 from intrapulmonary. We have now reduced that to 758. Okay, intrapleural started at 756 and has dropped to 754. Okay. Again, notice these are not huge drops in pressure. Okay, but it's just enough. Ooh, excuse me, I'm yawning. Just enough to increase the volume in your lungs enough to do normal inspiration. Now, expiration, if we want to breathe out, okay, your intrapulmonary pressures are going to have to increase, which will cause your lung volumes to decrease. This will force air out of your lungs. Okay, so notice air in here is coming in, air here is going out. So atmospheric pressure still has not changed, but our intrapulmonary and intrapleural pressures have increased. Okay, in fact, they have not only increased from our inspiratory numbers, but they've even increased compared to our at-rest numbers. Okay, so remember, if they just go back to rest or go back to 760 and 756, then we're just quote-unquote between breaths. We have to go above and beyond that. Okay, but again, notice intrapleural is still less than intrapulmonary. Okay, because we don't want our lungs to collapse. Last but not least, okay, one more review slide. In between breaths, your intrapulmonary pressure equals your atmospheric pressure. We are having no air movement here. We're also not having any muscle movement. Inspiration, your inspiratory muscles are going to contract, so your diaphragm, your extra intercostals. This will increase your thoracic cavity volume, increases your lung volume, which decreases your intrapulmonary and your intrapleural pressures. These will go below atmospheric pressure. This will allow air to move into your lungs. And when we are ready to breathe out, to do expiration, your inspiratory muscles relax. This causes your thoracic cavity volume to decrease. Okay, as your lungs do recoil, your lung volume will decrease as well. Intrapulmonary and intrapleural pressures will increase above atmospheric pressure, causing air to flow out of the lungs. Okay, please, please, please make sure this slide and this slide make perfect sense.